Yeah, hi, this is Dr. Shafiq Cheema. I'm Diploma at American Board of Internal Medicine and Nephrology and currently working as a professor and head of nephrology at Allama Iqbal Medical College. Today we will be talking about hyperkalemia and hypokalemia in the medical lecture series on this YouTube channel, Good Doctors by Dr. Shafiq Cheema. So let's start with the case so that we have an understanding. So this is a 62-year-old man with mild chronic kidney disease, plasma creatinine around 2.1, and potassium was normal, started on low sodium diet for hypertension. 2 weeks later, he notices weakness in lower extremity and inability to get up from the chair. On physical examination, slightly decreased skin turgor and marked proximal muscle weakness was found. And on the laboratory testing, sodium was 130, potassium 8.2. The normal upper limit is like around 5. And bicarb is low, creatinine is 2.7, pH 7.32. And ECG is shown. And as you could see on ECG, tall peak T waves. These tall peak T waves, which are present diffusely, is hallmark for hyperkalemic, one of the hyperkalemic ECG changes. So the question arises, what do you think is the most likely factor responsible for the elevation in plasma potassium concentration? Obviously, patient did have elevated creatinine with decreased GFR and chronic kidney disease. So people with chronic kidney disease are more prone to hyperkalemia. That is number one, because they cannot get rid or excrete most of the potassium through the kidney. So this patient, when he started low potassium diet, he actually ended up taking one of the supplement which has KCl, because many know a low potassium diet has KCl in it rather than NaCl. So that led to very high potassium. And how would you treat this patient? Obviously, there are ECG changes. It has to be treated promptly, and we will discuss that. But if the potassium would have been 6.4 without any ECG changes, then it was not an emergency. Then you could basically get rid of that salt and maybe give 1 or 2 dosages of Kayexalate, the potassium binding resin, to decrease the potassium. And you didn't have to give calcium gluconate, dextrose, insulin, or bicarbonate, etc. So the lesson from here is you always would develop hyperkalemia in the setting of reduced kidney function, because if kidneys are working normally, kidney have ability to get rid of any extra potassium load. So what are the common ECG changes? Initially, you get peak T waves like in this. Then there is a prolongation of PR interval and QRS interval. There could be AV conduction delay, and you could have absent P waves, widened QRS complex, and then sine wave pattern. And eventually you could develop ventricular fibrillation and asystole and die. So hyperkalemia is an emergency. So the lesson number 2 is hyperkalemia has to be treated promptly. So these are the changes of high potassium. You could get tall peak T waves, widening of the QRS complex, P wave could be absent, and eventually sine wave pattern and VTAC and ventricular fibrillation. So what are the common causes? Increased potassium intake is never the cause unless there is reduction in the kidney function, or GFR is low, or there is chronic kidney disease. Then comes pseudo hyperkalemia in patients with leukocytosis, elevated platelet count, or hemolysis. They could have pseudo hyperkalemia. Similarly, ischemic blood drawing or hemolysis during blood drawing could also lead leaking of the potassium out of all these cells in the test tube, which could lead to hyperkalemia. And actually, in the serum, there would be no significant hyperkalemia. It only happens in vitro. So this is pseudo hyperkalemia. And the way to differentiate this from the true hyperkalemia is to check plasma potassium. In the plasma potassium, since you get rid of all the clotting factor with heparin, So the cells would not break down by clotting, and there would be no release of potassium, and hence you could differentiate. So serum potassium will be high, plasma potassium would be normal. Then there is redistribution, the transcellular shift of potassium into the cell. Normally in the total body, in a 70 kg man, 50 milli equivalent of potassium is present in the extracellular compartment. But the total body potassium content is 4200 milli equivalent. So most of the potassium, more than 95%, is present within the cells. So any little change like metabolic acidosis, insulin deficiency, hyperglycemia, exercise, beta blocker, hyperkalemic periodic paralysis will actually end up moving the potassium from within the cell to the extracellular space. And remember again, there is a significantly more potassium within the cells. So there could be a significant hyperkalemia, and this is called redistribution hyperkalemia. Then obviously decreased kidney function by impaired sodium reabsorption is the mechanism in hypoaldosteronism, Addison's disease, heparin, potassium sparing diuretics, ACE inhibitor, ARB, non-steroidal anti-inflammatory drugs. I highlighted ACE-ARB because ACE-ARB with spironolactone combination in the setting of reduced kidney function is a major cause. This is what you would see common in your clinical practice. Similarly, Bactrim or Septron, in which trimethoprim could cause hyperkalemia. Oliguric kidney disease, advanced CKD, end-stage kidney disease, you will retain potassium within the body, and hence you could have hyperkalemia. Pseudo-hypoaldosteronism, in which the potassium will be high, and so would be aldosterone and renin level, that could also lead to hyperkalemia. The other possible mechanism would be increased chloride reabsorption. It could lead to hyporeninemic hypoaldosteronism, which usually happens in diabetics, causing type 4 renal tubular acidosis. So type 4 renal tubular acidosis is very common cause in diabetics, and the mechanism is hyporeninemic hypoaldosteronism. Because whenever there would be deficiency of aldosterone, you will end up retaining potassium. Cyclosporin toxicity causes by the same mechanism. And whenever there is a decreased flow, distal flow to the kidney, there would be less reabsorption of the sodium and hence less excretion of the potassium. And that could also lead to hyperkalemia. So there are so many other drugs, but these are the mechanisms with some important drugs which could cause hyperkalemia. So how do you treat acutely severe hyperkalemia, potassium more than 6? You immediately give calcium gluconate, because calcium gluconate will antagonize the cell membrane effect on heart muscles. And then you give insulin and dextrose because that will move the potassium into the cells. And bicarbonate, if there is metabolic acidosis, beta-2 agonist, these all will move potassium within the cells. And diuretics and cation exchange resins and dialysis, these last three, will get rid of the potassium from the body. This through dialysis, this through the stools, and this through the urine. So this just antagonizes the membrane, this moves the potassium into the cells, and this basically permanently removes the potassium from the body. If you have chronic mild hyperkalemia, you could treat the underlying cause like CKD, low potassium diet, you could practice acidosis, things like that help. So I made this algorithm because there is a lot of confusion in terms of treatment of hyperkalemia. So if you have potassium of more than 5.5, okay, you have hyperkalemia. Then you look at it. If it's mild to moderate, less than 6, you consider, you rule out pseudo hyperkalemia, you rule out hemolysis, you tell the patient to take low potassium diet, you treat the underlying cause, you correct metabolic acidosis, you hold a decreased ACE inhibitor, ARB, and spironolactone, and you could also give them low dose Caxylate or the newer medicine to decrease potassium like Beltaza. You could add some loop diuretics. So you could make some changes so that you don't have to treat it immediately and potassium stays less than 5.5. But if you have potassium of more than 6, The first thing you do an immediate ECG and see if there are any peak T waves, absent P waves, white QRS, sine wave. If you do have ECG changes, then you must give calcium gluconate right away, and dextrose, and insulin, and sodium bicarbonate, and even consider nebulization. Usually bicarbonate is only given if there is acidosis present, otherwise it will not help. But you could give calcium gluconate stat and dextrose 25 or 50% with some regular units of insulin. And if ECG has no changes and potassium is more than 6, then the only thing you could do is maybe not give calcium gluconate, but you do have to give dextrose and insulin and bicarbonate and maybe caxylate to get rid of the potassium from the body. And then it also depends on the kidney function. If kidney functions are poor, then you might need to consider dialysis and diuretics, because these are all temporary measures. You do it one time and then you repeat potassium while you are treating the underlying cause, because if you do not treat the underlying cause, then obviously the hyperkalemia will recur after some time. So once you have started this treatment, these temporary measures only work for a few hours, and then you do something permanent, either treating the underlying cause, removing AS, ARB, maybe dialyzing the patient, and always consult nephrology in this case. So hypokalemia seems very simple, but it's more complicated as opposed to hyperkalemia, because hypokalemia is more interesting. It means potassium is less than 3.5. Potassium intake on an average Western diet is around 1 millimole per kg per day. 90% of potassium is reabsorbed in the proximal tubule and loop of Henle. Net distal secretion, reabsorption in distal convoluted tubule and cortical collecting duct depends on potassium excess and depletion. It's basically the negative feedback is the serum potassium level and aldosterone level. So if there is a distal urinary flow increase, so there would be urinary potassium output that will increase. So people with polyuria will tend to have hypokalemia because they will end up losing more potassium. People with oliguria tend to have hyperkalemia because there will be less distal delivery of sodium, hence less sodium potassium exchange, more potassium will stay in the body. So low potassium could manifest in the form of muscle weakness, fatigue, you could hypoventilate, you could have weakness and paralysis of the respiratory muscle, you could develop rhabdo, arrhythmias, paralytic ileus, ECG changes like flat T waves, U waves, prolonged PR, white QRS complex. You could develop ventricular arrhythmia, digitalis toxicity. It also enhances bicarbonate reabsorption, so you could develop metabolic alkalosis. And you could also develop nephrogenic DI because hypercalcemia and hypokalemia could cause that. So these are the changes. And you could see these are after PQRST, this big wave is a U wave. So you could develop that in hypokalemia. So question arises, what are the possible causes of basically low potassium? So the causes are further divided depending upon is it because of the decreased intake? Because if it's decreased intake, the urinary potassium would be less than 15. And then transcellular shift, metabolic alkalosis, insulin, beta-2 agonist, anabolic states like when you are treating with the methicobal and B12, when new cells are being produced in pernicious anemia, they end up using more potassium. So there could be hypokalemia. And same is the case when you use GCSF in neutropenic patient. So all the things you use to treat hyperkalemia could actually cause hypokalemia, like bicarbonate, insulin, dextrose, and beta-2 agonist. Then it depends, the potassium deficiency. The causes could also be because of leukocytosis. You could also develop hypokalemia. Then there is a redistribution hypokalemia in which potassium moves into the cell as we just described. Then hypokalemia could be caused by extra renal loss. In extrarenal loss, the urinary potassium has to be less than 20 or 15. It could happen diarrhea, laxative abuse, villus adenoma, sweat losses, fasting, metabolic alkalosis could cause it too. And then the renal losses, which is most common, diuretics, primary hyperaldosteronism, hyperreninemic hyperaldosteronism, because whenever there will be more aldosterone, there will be more getting rid of potassium and more reabsorption of sodium. So that's another possibility. But whenever there would be renal loss, the urinary potassium on the spot urine would be more than 15 or 20. This is renin angiotensin aldosterone system as a result of dehydration or sodium deficiency or hemorrhage. Eventually, it leads to activation of and more release of aldosterone because the ischemia, renal hypoperfusion will lead to release of renin and hence activation of renin angiotensin aldosterone system, and that could lead to indirectly hypokalemia. So whenever there is hyperaldosteronism, and we could talk about primary hyperaldosteronism, in which usually aldosterone is more than 20, plasma renin activity could be less, and aldo and plasma renin activity is more than 30. But you have to check it off diuretics, beta blockers, calcium channel blocker, because they could affect the test results. The common cause, it's a very common cause for secondary or resistant hypertension. And then you need to differentiate it's hyperplasia or adenoma. Because adenoma, you need surgery to treat it. Hyperplasia could be treated with medicines like spironolactone. And then there is incidentaloma. You do CT scan, you find a mass in the adrenal, and then you do the functional workup to see if they have hyperaldosteronism or pheochromocytoma. So it's getting a little bit complicated for medical students maybe, but this was important because this is very under-recognized cause of hypokalemia. This algorithm is little complicated, but I'll just go over quickly. So whenever you have low potassium, you check urinary potassium first. If urinary potassium is less than 15 or 20, that means kidneys are not responsible for that hypokalemia. So you look for diarrhea and hypokalemic periodic paralysis and laxative abuse and villus adenoma kind of thing. But if potassium in the urine is more than 15, that means the loss is from the kidney. Then you look at patient's blood pressure. If blood pressure is elevated, then you calculate, then you measure their renin and aldosterone system. And all these are possibilities: renal artery stenosis, aldosteronism, primary aldosteronism, Cushing syndrome, apparent mineralocorticoid excess, and Liddle syndrome. So all these things would have elevated blood pressure as well as hypokalemia with high urinary potassium. But if blood pressure is low or normal, then you see if they have acidosis or alkalosis. If they have acidosis, the renal tubular acidosis could cause hypokalemia and acidosis. But if they have alkalosis, then you calculate their urinary chloride concentration and then you differentiate. But all these causes, diuretic, Bartter, Gitelman, magnesium deficiency, vomiting, all these would basically have hypokalemia, high urinary potassium, alkalosis, as well as normal blood pressure. So this is mostly for nephrology fellows, so I won't go into details. Let's look at a simple case to exercise on this table. A young female with profound weakness found to have potassium of 2.7, sodium of 136, bicarb of 17, and urinary sodium of 7, and urinary potassium is 12. So that means the loss is not renal. So then you need to take history of diuretic use, laxative, vomiting, meds. Young female sometimes will not give you history of laxative abuse. So this patient, even if he does not agree, she is probably using laxatives because that would have caused urinary potassium to be less than 15. So 24-hour urinary potassium or spot urinary potassium. If more than 15, then you look for the renal causes, what we discussed in the previous table, and you could calculate TTKG, acid base, blood pressure, hypertension, what we just discussed in the last table. How do you treat? Obviously, you want to avoid complication, correct the deficit and ongoing losses, and treat the underlying cause. Whenever there is a deficit of 1 millimole, like say potassium drops from 4 to 3, there is a deficit of 200 to 400 millimole in the body. So you could give more potassium. IV, never mix it in saline, never mix it in dextrose, always mix it in saline, because dextrose would cause further hypokalemia. If the hypokalemia is mild, you could obviously treat it with oral potassium supplement, but otherwise IV. But when you are giving IV, you have to use central line. From peripheral line, you could only give slowly because it could cause burning and sometime even sloughing of the skin. Maximum you could give 40 millimole per hour with peripheral and 60 with the central line. But usually if it's not life-threatening hypokalemia, you have to, you shouldn't give it more than 20 millimoles. So 1 ampule of KCl in Pakistan has 25 millimoles. So you just give it over maybe a couple of hours and mix it with normal saline, and that's how you treat hypokalemia. And obviously in every patient you do check if they have hypomagnesemia, because you do need to correct low magnesium first to be able to correct hypokalemia. And whenever there is a metabolic alkalosis, you need to correct hypokalemia for metabolic alkalosis to improve as well. So I hope this was helpful, and we will continue this lecture series, inshallah. And the next one I would have on hyponatremia or disorders of sodium metabolism. Thank you.